blood pressure cuff, sorry for that. This is the blood pressure cuff size. So we take the largest allowable mid-arm circumference for the bladder, and the length of the bladder is supposed to be 80%, and the cuff width is supposed to be 40% of the maximal allowable mid-arm circumference. So these are the cuff sizes for accurate measurement of blood pressure. For a small adult, approximately 22 to 26 centimeters, and for a conventional size is somewhere between 27 to 34 centimeters. For a large adult, 35 to 44, and for a adult thigh, it could be 45 to 52, which could also be used in cases of highly obese people. So the first method is auscultatory method. So for that, first we ask the patient to empty his bladder. He's not supposed to have any caffeine or should have exercised 30 minutes prior to the measurement. He should be sitting quietly and comfortably in the room for at least 3 to 5 minutes. Back should be supported and feet should be on the floor uncrossed, and right arm should be supported at heart level. So we'll estimate the systolic blood pressure by palpation. Then we'll reinflate the cuff to 20 to 30 mm Hg higher than this value. Now we deflate the cuff at 2 to 3 mm Hg per second. And systolic blood pressure is defined as the onset or the first sound that reappears after deflation, and diastolic blood pressure is usually recognized by the disappearance of sounds, that is the fifth carotid cough sound. We will always deflate 10 mm lower than the diastolic blood pressure sound, just to be sure, just to confirm the diastolic blood pressure reading. And we record blood pressure twice on each occasion. So oscillometric method is the second method which is being commonly used. It was demonstrated by Murray in 1876. So it basically measures the pressure variations in the blood pressure cuff, which are caused by the oscillation of the blood flow through the brachial artery. And the point of the maximal oscillation corresponds to the mean intra-arterial pressure. Then the BP values are then calculated by a derived algorithm, which is pretty complicated. So this oscillometric method is being successfully used in ambulatory as well as home monitors. So these are the various devices that are used for blood pressure measurement. Mercury sphygmomanometer, which is now obsolete, aneroid sphygmomanometer being currently used, oscillometric devices, ambulatory blood pressure monitor, oscillometric wrist blood pressure monitor, and automated monitors. So mercury sphygmomanometers, as I already mentioned, have been banned due to safety concerns. Android devices, they have compared the use of mercury versus Android devices, and they have found them to be pretty accurate. Automated electronic devices have become more popular. They are easy to use and as reliable as the carotid cough sound method. Wrist monitors are usually smaller than the arm devices, and they can be used in obese people. But a potential problem is the error which is introduced by the hydrostatic effect of differences in the position of the wrist relative to the heart. Finger monitors are usually inaccurate and therefore aren't being used. So oscillometric devices, they measure MAP, calculate SBP and DBP, but they need to be calibrated regularly. So these are several manual as well as automated oscillometric devices. Then ambulatory blood pressure monitoring also utilizes oscillometric methods. It is a 24-hour monitoring, and readings are downloaded into a PC. So BP, there are a lot of physiological variations of blood pressure due to age, sex, diurnal variation, stressors, excitement, gravity. Hence, adequate measurement, it becomes very imperative in diagnosis of hypertension. So methods for the diagnosis of hypertension which are acceptable are office-based, home blood pressure monitoring, and ambulatory blood pressure monitoring. So these are certain patterns of blood pressure which we need to know before proceeding forwards. So one is white coat hypertension and the other is masked hypertension. So this is the diagnosis and management of white coat and masked hypertension phenomena. So white coat, as the name suggests, is elevated office blood pressure reading but not 24-hour ambulatory or home blood pressure reading. Whereas masked hypertension is an elevated out of office reading but not the office blood pressure reading. So for white coat hypertension, usually lifestyle changes and annual follow-up is necessary, suffices, and we consider drug treatment in patients with high or very high cardiovascular disease risk. But for masked hypertension, lifestyle changes, and we have to consider drug treatment. So for white coat hypertension, anxiety seems to be the main cause, and having your blood pressure in the office taken by a nurse or a technician rather than the clinician may minimize the white coat effect. So in cross-sectional studies, its prevalence has been studied to be around 15 to more than 25%. So this was a study in 1987 which showed the effect of unfamiliar doctors versus nurses on a patient's peak blood pressure. So the effect was a little ameliorated as far as the nurse was concerned, and it attenuated with time. So the cardiovascular risk associated with white coat hypertension may be slightly higher compared with persistent normotension, but well below the risk associated with masked or sustained hypertension. And patients with white coat hypertension are also at high risk for developing sustained hypertension. Now let's talk about masked hypertension. This is the reverse of white coat hypertension, and as many as 10 to 40% of patients who are normotensive by conventional clinical measurement are hypertensive by out-of-office methods. So masked hypertension has been associated with an increased long-term risk of sustained hypertension and cardiovascular morbidity. Then we need to talk about nocturnal blood pressure and non-dippers. So normally blood pressure decreases by 10 to 20% at night, that is dipping. So the average nocturnal blood pressure is approximately 15% lower than the daytime values in both normal and hypertensive patients. So failure of the blood pressure to fall by at least 10% during sleep is called non-dipping, and the underlying mechanisms are not clear, and there is also some evidence that probably melatonin plays a role. So independent of the degree of hypertension, non-dipping is a risk factor for development of LVH, heart failure and other cardiovascular complications. Extreme dipping, on the other hand, which is more than 20% nocturnal decline in blood pressure and a large morning increase in blood pressure, are also potentially deleterious. Non-dipping has also been associated with microalbuminuria. It may also be a risk factor for decline in GFR and ESRD. So this is the blood pressure reading of risers versus non-dippers, dippers and extreme dippers. So automated electronic devices are now being commonly and exclusively used for home blood pressure monitoring, ambulatory blood pressure monitoring, and even increasingly for office blood pressure measurement. So for office blood pressure device requirements, we usually need an automated electronic upper arm cuff device, or even a good quality shock resistant Android device may suffice. So most often and most used and often the only method used for hypertension detection, that is office blood pressure measurement. So the methodology is almost the same: no smoking, caffeine, food, exercise, emptying of bladder, quiet room, comfortable temperature, rest, and no talking in between the measurements. Device which cuff to fit arm size, back supported, and validated electronic device, and feet flat on the floor. So we'll take 3 measurements at 1 minute intervals and use the average of the last 2. So we need at least 2 to 3 office visits at 1 to 4 week intervals, depending upon the blood pressure level and the CVD risk, and they are usually required for evaluation of OBP. So in most cases, the diagnosis of hypertension should be confirmed by out-of-office readings. If not possible, then we take more office readings. So interpretation of the average office blood pressure measurements per visit. So for diagnosis of normal to optimal after the mean, if it is somewhere between less than 130 by 85, so the action is we just reassure them and we'll follow them 6 monthly. For high to normal blood pressure after the office blood pressure readings, we will consider masked hypertension. For hypertension grade 1, that is in the range of 140 to 159 and 90 to 99 in diastolic, we should consider white coat hypertension. And in these strata of patients, we should also go for out-of-office blood pressure monitorings. And for hypertension grade 2 and 3, that is for more than 160 by 100, that means sustained hypertension is a highly probable cause. So we'll confirm, and we could use out-of-office blood pressure measurement for these patients. So any clinical measurement of a blood pressure may be regarded as a surrogate measure for the true blood pressure, where office blood pressure recordings are like a snapshot of the hemodynamic profile of a patient. So 2 techniques have been developed to improve the estimate of true blood pressure, that is ambulatory and home monitoring or self-monitoring. So ambulatory blood pressure typically involves measuring blood pressure at regular intervals every 20 to 30 minutes over a 24-hour period while the patient undergoes normal daily activities including sleep. So the portable monitor is worn on a belt which is connected to the standard cuff on the upper arm. So when complete, the device is connected to the computer that prepares a report of the 24-hour, daytime, nighttime, and the sleep and awake average systolic and diastolic blood pressure and heart rate. So basic requirements that we perform ABPM preferably on routine working day, and 10 to 15 minutes are needed to initialize and fit the device. Then frequency of measurement is usually 20 to 30 minutes during day. Cuff size according to the individual's arm circumference. Then we have to fit the cuff on the bare non-dominant arm, take a test measurement, and provide instructions to the patient. When do we remove the monitor? We remove the monitor after 24 hours. We determine day and nighttime periods only according to patient's report, and we'll repeat ABPM if we have less than 20 valid awake or less than 7 asleep BP readings. When to repeat? So to ensure adequate BP control, particularly in patients where they have increased CVD risk, in cases of uncontrolled hypertension, we might perform it every 2 to 3 months, but for controlled hypertension, we do not need to go further beyond performing it annually. Now, indications. For initial diagnosis, to diagnose hypertension, to detect white coat and masked hypertension, to identify nocturnal hypertension and non-dippers, and to assess blood pressure changes due to autonomic failure. In treated hypertension, to again identify white coat and masked hypertension, to confirm the diagnosis, to ensure 24-hour blood pressure control, to confirm symptomatic hypertension, to assess nocturnal hypertension and non-dipping, and disagreement, if there is a disagreement in diagnosis between office and home blood pressure, we resort to ambulatory blood pressure. So interpretation. So the data that is provided by ABPM includes 24-hour average blood pressure, daytime, nighttime, systolic blood pressure load, diastolic blood pressure load, and nocturnal dipping. So these are the diagnostic thresholds. For normal, we consider 24-hour systolic by diastolic as less than 115 by 75, and hypertension if the blood pressure is more than 130 by 80. For daytime, we consider hypertension of more than 135 by 85, and for nighttime, we consider hypertension of more than 120 by 75. So this is a study that demonstrated the prognostic value of ambulatory blood pressure recordings in patients with treated hypertension. So a higher ambulatory systolic or diastolic blood pressure predicted cardiovascular events even after adjustment for classic risk factors, including office measurements of blood pressure. So this was a study that showed superiority of ambulatory over clinical blood pressure measurement in predicting mortality, the Dublin outcome study. So these results have two important messages. One, that ambulatory measurement of blood pressure is superior to clinical measurement in predicting cardiovascular mortality, and nighttime blood pressure is the most potent predictor of outcome. So indications of even the JNC7 and the WHO have given indications for ABPM in white coat, labile, resistant, hypertensive episodes, and postural hypertension. Also, another study which demonstrated antihypertensive treatment based upon conventional versus ambulatory blood pressure measurement. It showed that adjustment of antihypertensive treatment based upon ABPM monitoring instead of office blood pressure measurements led to less intensive drug treatment with preservation of BP control. So now the third method, that is the home blood pressure monitoring. So it is widely used. It provides multiple blood pressure readings away from the office. It also identifies white coat and masked hypertension, and it is recommended as the best method for long-term follow-up of treated hypertension. So advantages: widely available, acceptable, confirms uncontrolled and resistant hypertension, detects white coat and masked hypertension, improves adherence, and can reduce healthcare costs. Limitations: inaccurate devices, inappropriate cuff devices are often used. Monitoring may be too frequent, may induce anxiety to some patients. Possible selective reporting of blood pressure readings by the patients, usually omitting the higher blood pressure values, and doctors may estimate instead of calculating average home blood pressure. So we use a validated electronic arm cuff device. So before each office visit, we need at least a monitoring of 7 days, minimum of 3. So we need 2 blood pressure monitorings, that is morning and evening, before drug intake. The patient should be again subjected to 5 minutes rest, and 2 measurements should be taken with 1 minute interval. For long-term follow-up, we can duplicate measurements once or twice per week or month. So this is a chart that the patient is asked to make, that is from day 1 to day 7, and we are recording morning evening blood pressures, preferably before any drug intake if the patient is already hypertensive, and we discard the first day's readings and then we take out the average of the next 6. So individual readings have little diagnostic accuracy. Average home blood pressure of 135 by 85 indicates hypertension. So clinical utility of office and out of office blood pressure measurement methods. So as far as screening goes, office blood pressure is a better tool as compared to home and 24-hour ambulatory. Initial diagnosis, 24 ambulatory trumps both home and office blood pressure readings. Treatment titration, we are using home and 24 ambulatory more than office blood pressure readings. For follow-up, again, home blood pressure provides a better measure as compared to office and 24-hour ambulatory. So this is another study that showed role of home blood pressure monitoring in overcoming inertia and improving hypertension control. So when we compared home blood pressure monitoring with clinical blood pressure monitoring, we saw that home BP had the potential to overcome therapeutic inertia, and it led to a small but significant reduction in systolic and diastolic blood pressure. So this is a chart that shows the blood pressure patterns that can be determined by means of ABPM and other methods. So ambulatory determines the true or the mean blood pressure, as does home blood pressure. Diurnal blood pressure rhythm is better assessed by ambulatory and home blood pressure. Blood pressure variability is also best determined by ambulatory blood pressure, and duration of drug effects can also be determined by ambulatory blood pressure. So is home blood pressure equivalent to ABPM? So as far as ambulatory is concerned, we get readings daytime, nighttime, 24 hours, and in home blood pressure we get diurnal readings. So BP variability can be thoroughly tested as far as ABPM is concerned, whereas in home it's a day-to-day affair. For prediction of outcome, ambulatory blood pressure is the best. As far as nighttime hypertension prediction is, nighttime hypertension prediction can also be done, and home blood pressure is superior to clinical blood pressure, but definitely is a tad little behind ambulatory one. So ambulatory might be helpful in improving compliance, but the best evidence of improving compliance comes from home blood pressure monitoring. So the conclusion is that ambulatory monitoring can be regarded as the gold standard for prediction of risk related to blood pressure, since prognostic studies have shown that it predicts clinical outcome better than conventional blood pressure measurements. In spite of high cost, it should be offered more and more patients to effectively deal with the menace of hypertension. But if that is not available and it is not cost effective, then home blood pressure monitoring is another best method for supplementing the diagnosis of hypertension.
Questions from?
You didn't mention about the measurement of blood pressure in all the four limbs. What is the significance of that? You just mentioned about brachial artery.
So
The second is the now this we have these oscillometry methods of BP monitoring apparatus. So how to validate it and how frequently we should calibrate it? Because that is a very important number. Initially we all use, for years we were using sphygmomanometers, so which is still considered as a gold standard. Because these oscillometers, they have to be actually calibrated. And now there are some instruments available which will give you 3 readings, and then you can have the average of 3 readings. So what is is there any use of those instruments?
yes, so these oscillometric methods are being used by the automated blood pressure machines. So they need validation and they need calibration yearly basically. So validation has been done by experimenters. So validation is done in the form that they have to be close to more than 5 mmHg of blood pressure for the first 6 months, and they have to be close to more than 10 mm of Hg of blood pressure calibrated by other methods for the next 1 year. So they need to be calibrated, and in case of these devices, in case of pregnant females, in case of kids, they need to be even looked into more, because the regular oscillometric methods when calibrated do not suffice for this strata of population, including kids and pregnant females. So that is the
Where to get these calibrated?
So usually the calibration is done by recommendations from it has been done by recommendations from the British Society as well as the American Society. So there are certain recommendations for for doing validation of these instruments.
No, I mean now I have got blood pressure apparatus in my room, OPD. So I've never sent it for any calibration so far.
Buy a new one, Dr. Manoj.
The manufacturer will calibrate it.
No,
for you.
every
You have to
nobody
ask for
does that.
servicing and they
No,
will
but they-
Nobody does that.
And I think the
Hospitals, they have to,
biomedical
They have to do it.
biomedical, they're doing it on a regular basis,
Yeah.
they take charge.
Hospital biomedical data.
And do you recommend measurement of blood pressure in all the 4 limbs?
So usually it depends upon the method that we're using. For normal home blood pressure monitorings, we use the right arm. But in cases of patients who are CKD patients with a dialysis access or some sort of a disability, we could also use the non-dominant arm. Even in automated blood pressure measurements where we use the cuff from the dominant hand, we use the non-dominant hand as well. Then legs, thighs are typically used in those patients where patients I mean, usually we do not go to the, unless and until there is a blood pressure discrepancy.
No, you have supposed the patient is coming to you with aortoarthritis.
Dr. Reen, what you are referring to is see,
This
the
idiopathic
monitoring.
hypertension talk.
But see,
No.
what Dr. Balla is asking, it is quite important to check blood pressure on both the upper limbs at least. Otherwise, you are likely to miss Takayasu, you are likely to miss coarctation of aorta, you are likely to miss atherosclerosis. So it's extremely important. All these are the monitoring and of course the way forward. But on the first visit and when you are wanting to make a diagnosis, if you have ensured that all four limbs blood pressure at baseline is normal, at least you can rest assured that everything is fine, and subsequently you may not. All these what you are talking about are the some peculiar situations whereby, of course, in a dialysis patient, of course, in an amputated situation, of course. So these are these subsequent, but it's very important for all of us to remember. That's one, and secondly is to check for postural hypertension on at least in the baseline. The both are equally important because if you haven't checked for it, you are likely to miss and subsequent.
Yes, I think that is a very important point which again you have to highlight. That's postural fall has to be.
All three, supine,
Yes.
standing, erect, all.
So now that you've done this overview, how do you want to go back to your office and check whether your office blood pressure readings that you get every day are being done by the recommended, and if not, how would you change it at Max Arcade?
Using all these parameters. First, I mean, so we have to ensure that whatever may be said, standardized office blood pressure measurement is still the first.
So my question is more specific. So when your patient comes into the clinic and your nurse is doing the blood pressure and that reading comes to you on the sheet in the clinic, how is she doing it? Is she doing it in the manner that is recommended here? If not, what would you ask them to do to change the daily BP that you get day in, day out?
So I would like to tell them about the entire scenario of how a patient should be there, he should be well rested, of how he should not consume, he should be positioned properly, and the proper cuff sizes should be used.
Let's be pragmatic, I think. All that can never be done.
So-
It's not
So at
done.
least
So-
we can do
So,
we can do educational training of
So the question is,
Staff.
and I think this is something that everyone should go home with, that if we want good blood pressure readings in our clinics, we will have to push our systems to actually ensure some mechanism of getting good standardized office blood pressure. And Dr. Bhalla already mentioned these automated blood pressure machines that do a 3 read. So if each machine is somewhere between 5 to 7,000 machines, depending on whether you're getting an home run or micro dive. If you hand over these machines to your nurses and say that this is the automated machine that you have to use, they have no way to bypass the system. You press the button, it will only give you a reading after 5 minutes. So then the education actually is going to make a difference, because now with this automated BP machine, they can't give you a reading till 5 minutes have gone by. There'll be hue and cry because now the cycling of patients is going to be slower. So, but if we value blood pressure, if you value the validity of the readings we are getting, I don't think we can bypass what is out there. That the validity of office blood pressures is only if they're resting for 5 minutes in a quiet room with 3 readings and the average of 3 readings. So if we value high blood pressure and the validity of the readings that we base our treatment on, we have to push ourselves, our hospitals, and our nurses to get into this method. They can do 3 readings themselves and not change the machine, or we change the machine for them and they have no way of bypassing it. So I think this is something that I would want everyone to kind of take home and push their organizations as well as ourselves. If the organization doesn't do it, then in your clinic you will have to do it. So I think that's something which I would want everyone to kind of go home with.
So there's a lot of discrepancy between the ideal situation and what we actually practice. And I think our pursuit should always be trying to move towards the ideal situation. We all know the constraints do not allow us for all practical purposes. We know that the way you have emphasized the importance of ambulatory blood pressure monitoring, we all know the importance, yet as hardly any significant percentage of people getting it done on a regular basis, and that's why we go in for the next best, that is home-based this thing. So I think rather than, and we should actually be giving the least importance to the office-based blood pressure the way we take it, and it's not about criticizing the various. You see, we also have to be mindful of what happens in the governmental sector. It is not going to be possible to have separate rooms for this thing, but we know, and here today we are discussing about the ideal situation. We should all go back knowing what is ideal and then trying to see whether that is possible to be inculcated in our daily practices. But the sort of emphasis we need to give to everyone, all our patients, that they should preferably buy their own good machines, get them regularly calibrated, I think is the way forward. Otherwise, we tend to make huge blunders and unnecessary over or under treatment. The way you emphasize the importance of mass hypertension, of course we can be little complacent with white coat hypertension, but certainly not with mass hypertension.
Last question. After reading all these guidelines, what are your targets for your patients that you see on a day-to-day basis? And how are you targeting your blood pressures that you see for your patients? So what's kind of your threshold that you use for your patient that you see?
And if I may add to Ajay's question, the extension of that, how low can you allow the diastolic blood pressure? And that's very important. I think we always try to bring down the systolic to 120. We should be mindful of what is happening to the diastolic and what would be the diastolic values you'll be comfortable with.
So right now we are targeting somewhere between 120 to 130 per systolic. We are going as low as that according to new guidelines. As far as the global burden of Indian hypertension is concerned, if we do pursue the American guidelines, which are advocating a lower blood pressure goal for patients, we have seen that it has a considerable effect in decreasing the CV morbidity mortality. I think that would apply to the Indian population as well, though it's a different strata. We're not Caucasians, we have a different profile. But with the increasing burden, I think if we do pursue the aggressive control of blood pressure monitoring, it might help us in the long run.
I think Sprint has been a game changer, and it was a good learning experience for all of us who believed that 140/90 probably was as good, less than 140/90. So diastolic, Dr. Kher, your comments, because you see we are in a dilemma. I mean, you see, you try to achieve the systolic goal, and so many times you find this diastolics falling to as low as 40, 50.
Yeah, I will agree that is a question. It may not be important in all the patients, but I think it will be important probably in patients with comorbidities, cardiac involvement, those with strokes, vascular disease, and I think that's where you will be concerned about. And I think the answer to the Ajay's question which he asked you, I would think that if there is a younger 20, 25, 30-year-old person, in that patient, you are looking at life ahead of another 40, 50 years, then I will be very, very important. Hypertension is the most important, number one cause for comorbidities. All the comorbidities, mortality, every mortality that you don't know. Hypertension is the etiology for that. So I would be very much concerned about the blood pressure control in this 30-year-old person in comparison to somebody who is at 75 years. I'm not saying that the blood pressure should not be controlled. Sprint trial, Dr. Kula was talking about, again showed that elderly population. It is not that we used to believe that you add
Age to
40 or age to 100 and then control blood pressure, and I don't think that's been proven to be right. And I think in them also, but obviously in an elderly patient who has postural hypotension is going to fall or something, I would be concerned about that. And therefore, controlling blood pressure and monitoring these patients more frequently to see what is the optimal level of blood pressure that I can achieve in such a patient so that he remains symptomatically good and his quality of life is not affected, would be an important factor. And in those patients, probably diastolic blood pressures going down to less than 50s or 40s or 60s sometimes does worry me as well. And in those patients, I would probably tend to not, as I said earlier also, where probably these levels go down, I would not be. But in a younger patient, I don't think I would be worried about it. That's what my take.
Yeah, so the J-shaped has to be, curve has to be kept in mind.
I think G-shape again there is a discrepancy.
J-shape is a
Controversial
controversial
thing.
I'm not so sure.
So for the diastolic.
Yes, I'm
and
not
for
so
the
sure about that. This is
early,
validated in science.
Yeah,
But yes,
I
but
will-
in an elderly population, yes, I would be.
And that's where it is important actually. So this is again an epidemiology which shows that there is a J-shape, not realizing whether it is deliberately decreasing the blood pressure to that level or it is a spontaneous blood pressure which is lower and impairing the diastolic coronary perfusion. So I think in a younger patient I would not worry, but in the elderly patient here he is likely to have vascular disease, definitely I don't want to go very low on the diastolic pressure.
And what is the Indian study you said mentioned, the Indian guidelines?
The Indian study of 2019, sir, they have this is the fourth updation and
The Indian guidelines by whom?
Hypertension. Indian Society of Hypertension.
Indian Society of Hypertension. And what was their values?
So their values were almost similar on the lines of
European.
140/90.
Yes, sir, 140/90.
Yeah, see. Only thing is they added third category more than 180,
Yes.
I guess.
And JNC 8 you didn't mention, the JNC 8, what are the values now? 140/90?
So basically, AJ has exceeded that, so.
I think bottom line should be less than 130 and 80 for our patients. I think that's what I would say. But yes, elderly patients and others will not be.
Why
And
don't
again,
we
it's-
use
So but that'll be
ambulatory more and more?
in contrast to what Sprint says. Sprint says 120. So I think.
So, I actually think rather than home monitoring, our health institutions should go more towards ambulatory monitoring. And when I said that, Ajay said money. So money is important, but a device costs 1.5 lakhs, I believe. And so if we were to do it at least once or once in 6 months, once in a year, it may definitely add value to our blood pressure control.
So we
So
are.
I think we should move more
We are
towards
already
ambulatory.
using more and more. I thought all of you are, especially Sun Pharma, is helping us to do these, and I think they have collected more than 70,000-80,000 patients, Indian patients now, in whom they have these ambulatory blood pressure. They do it free.
Yeah,
They
Eric
pick it
also
up.
does it. I've
This
been
is said,
sending-
Eris is part of the Sun Pharma,
Oh,
so
okay.
they help
So
you
I've
to
been
do
sending
this.
to Eris.
Yeah, this is what I'm saying. So we are indirectly using it. Yes, asking patients to buy it and all that will
To
be
buy
a
it and
different.
delivery is too
will be a-
much.
But sir, the inertia, even though we all know it's free of cost, even then if you were to ask, how often do we get it done?
Yeah.
And
So
we
in fact,
know
Dr.
some-
Definitely use it.
I had to change
That's
from
my conviction.
3 readings to 1 reading. Because that was taking more time.
That's what.
Yes.
Time.
हमारे क्लिनिक में तो मशीन ऐसी
वही ना
है जो आते ही देख ले पहले घर से आके देख ले
Deliberately I changed.
टच वाली होनी चाहिए, रीडिंग आनी चाहिए.
So I changed it from 3 readings to 1 reading.
यू वुड तुम तो कोई गाड़ी में लगा दो कोई
टच
आते
वाली
आते
होनी
कर
रास्ते में ही होनी
चाहिए. टच वाली होनी चाहिए.
Touch and go.
So I think now we'll take a break for tea for, I think I'll come back at
20
Yeah.
20 minutes and we'll come back at 11:50, so we'll come back at 12:10.
Good. Yeah.
मैं तो बस मेरे को ना 3 बार से ऊपर मैं तो कंप्यूटर में नहीं सिंगल वाली
अब जो दूंगा उससे चलेगा।